On behalf of the panelists and Thrombosis UK, would like to welcome you to this webinar, which is called Management and Learning in Thrombosis and COVID-19. This is such an important subject in a very fast-moving field. And we have got the best of British medicine here. We've got two panelists who are academic, but much more than that, they are both very clear-headed and highly pragmatic. And I'm not sure they knew each other very well beforehand, but they both share those very important characteristics. So I'm thrilled that they agreed to take part. As you know, Thrombosis UK is a charity which aims to increase awareness of thrombosis and research in thrombosis in the UK, but this webinar has been taken up globally, and we have over 850 people registered with us from 54 countries. You are all really, really welcome, and I hope that you get something from this very pragmatic discussion that we're going to have. We're going to start first with Dr. Susie Shapiro, and she is working in the field of thrombosis and haemostasis, including haemophilia. She was the Oxford lead for both thrombosis prevention and anticoagulation, and currently she's director of the Oxford Haemophilia Centre. She's particularly interested in patient safety and's got projects to optimize anticoagulation, which have won national awards, and she has got a lot of research going in haemophilia. She is an MRC clinical fellow investigating cancer-associated thrombosis. But today, she's going to talk to us about VTE prevention and COVID-19. Susie, welcome. We're expecting good things. I know you'll do it. Thank you.
So first of all, I just need great. So Beverley, Joe, Thrombosis UK, thank you very much for the invitation to speak on a really challenging topic that I think is probably causing all the clinicians on this call a big challenge in the tension of our standard thromboprophylaxis. Is it enough for patients with COVID? Should we be changing it before we know the results of randomized controlled trials? And so what I would like to do is just look a little bit about the evidence around the UK standard thromboprophylaxis for medical inpatients, look at the rate of VTE patients in COVID, and start to look at the concerns about why our standard may or may not be enough. And then to have a think about if people want to change our standard guidelines before we have the results of randomized controlled trials, what you may think about doing. So to begin with thromboprophylaxis in medical inpatients, the two landmark trials were Medinox and Prevent, which trialed enoxaparin and dalteparin at standard dose against placebo in unwell medical inpatients. There was a baseline risk of VTE between the trials of 5 to 15%, and this was significantly reduced with standard thromboprophylaxis by about 50%. There was a trend upwards for increased bleeding, but the bleeding overall was low. So that was general ward patients. What about ICU? It's remarkably difficult actually to get data on the baseline risk of VTE in ICU. It's been reported that we think that the baseline is higher for ICU patients and potentially 28% without low molecular weight heparin, but that baseline risk will vary dependent on the reasons for admission to ICU, whether or not someone's had recent surgery, underlying comorbidities. But it's important to remember that these ICU patients, although they have a higher rate of thrombosis, they are also higher risk of bleeding. So up to 80% of ICU patients will have one or more episodes of bleeding, although the vast majority is minor. And it's been reported that the baseline risk of bleeding in ICU without prophylaxis is about 2.7% major bleeding. This next slide I've just done to try and give us an idea of the rates of VTE and bleeding that we generally expect to see in our ICU patients out with COVID. So this is actually a randomized controlled trial of deltaparin against heparin thromboprophylaxis in the pre-COVID era. Overall, there wasn't a significant difference between deltaparin and heparin, so I'm really just using it to look at the overall figures. Some of the things that I want to draw out that are important, because I think it will help us to compare some of the more recent COVID VTE data. So it's a big trial, almost 4,000 patients. It excluded major trauma and orthopedic surgery. It did include ultrasound scan screening for DVT, and it followed up until discharge from hospital or 28 days. Overall, the VTE risk was about 10%, with major bleeding at about 5.5%. What you see with the rates of proximal DVT and PE is proximal DVT was about 5.5%, with PE 1 to 2%. So that standard 2/3 DVT and 1/3 PE is a typical proportion. There's a bit of catheter-related thrombosis at 2%, and also time course-wise, 85% of VTE occurred on ICU, 15% of reported VTE occurred when the patient was on the ward afterwards. So that's standard dose weight basing in medical inpatients and the ward. How about weight-based dosing? So if you look at the BNF and the SPC for the low molecular weight heparin, the standard thing is to give everyone fixed dose. However, there is a body of evidence to suggest that we should be doing weight-based dosing for VTE prevention. So there's an inverse correlation between anti-10A levels and body weight after a prophylactic dose of enoxaparin in surgical patients. And also there's quite a few studies in bariatric surgery where the anti-10A is more likely to be in range with a lower incidence of VTE, importantly, when low molecular weight heparin is adjusted for body weight. So it seems sensible to adjust for body weight. How about extended thromboprophylaxis for medical inpatients? Now, this has been looked at a lot in big randomized controlled trials, and we don't do it in the UK. The 5 biggest randomized controlled trials are shown here. The top 4 trialed either enoxaparin or a DOAC from being an inpatient throughout the inpatient admission as well as extended, and compared that to a standard course of low molecular weight heparin when someone was an inpatient. Mariner, I'll go on to in more detail in the next slide. It's a little bit different because all patients got low molecular weight heparin when they were inpatient, and they only got randomized to rivaroxaban or placebo on discharge. All of these were big randomized controlled trials with 6,000 to 12,000 patients in them. A meta-analysis shows overall that doing this reduced the risk of symptomatic VTE or death from 1.2% to 0.8%. However, it was offset by an increase in major or fatal bleeding from 0.3% to 0.6%. So they do it's extending thromboprophylaxis in a group of patients that were considered high risk of VTE, does reduce the risk of VTE, but it increased the risk of major bleeding and fatal bleeding as well. So just to have a look at Mariner, because I know from colleagues around the UK that some people are starting to use rivaroxaban as extended thromboprophylaxis in the COVID era. So this was a randomized controlled trial of 12,000 patients. On discharge, people were randomized to placebo or rivaroxaban 10 milligrams for 45 days. They also dose reduced to 7.5 milligrams for creatinine clearance less than 50. They took the highest risk medical patients based on hospitalization, significant medical illness, and additional VTE risk factors. With that, the primary outcome here was symptomatic VTE or death from VTE. There was a trend downwards with rivaroxaban, but it didn't reach significance. There was a trend up for major bleeding, and there was a significant increase in clinically relevant non-major bleeding. So in this subgroup, it's arguably it doesn't reduce symptomatic VTE or death, but it will increase overall bleeding. Very quickly, mechanical thromboprophylaxis, because we've had a few questions submitted around this. We don't standardly use mechanical thromboprophylaxis for medical inpatients who are allowed to have low molecular weight heparin. We would consider it for patients who can't. But the evidence overall for mechanical thromboprophylaxis is pretty weak. So classically, it's been used as an adjunct to low molecular weight heparin in surgical patients and is considered on ICU. There are graduated compression stockings and intermittent pneumatic compression as choices. So the GAPS trial got published last week and trialed in almost 2,000 elective surgical patients. Standard of care, graduated compression stockings and prophylactic low molecular weight heparin against low molecular weight heparin alone. And low molecular weight heparin alone was non-inferior. So certainly that would potentially drive a change in guidelines for that group of patients. Intermittent pneumatic compression has been looked at in ICU in a big randomized controlled trial, again, of 2,000 patients, mainly in ICUs in Saudi Arabia. An adjunctive IPC in that trial did not significantly reduce DVT and VT compared to low molecular weight heparin alone. The CLOTS-3 trial of IPC and stroke against placebo, again randomized a lot of patients. IPC significantly reduced DVT, but didn't affect 28-day mortality and did increase the risk of skin breaking. So in general, in the UK, we would consider still thromboprophylaxis in medical patients who have a contraindication to low molecular weight heparin. I would consider IPC before the graduated compression stockings. But then you have to take into account the mobility of the patient, how they will tolerate it, and potentially contraindications such as skin fragility. So, VTE rate in COVID. Now, there have been a huge number of papers around this, initially case reports and now cohort studies. And what I'm going to do, I've got two slides, one looking at the VTE rate in ICU and the other one looking at the VTE rate in a mixture of ICU and ward patients. I've taken the two biggest cohort studies that have been reported so far to discuss. The slides are quite busy. That's because I've included some details that I think are really important to look at and to think about, rather than because the headline data can otherwise be quite scary. Okay. So the first study is CLOT from the Netherlands and looked at 184 patients from ICU. All of them received thromboprophylaxis, at least at standard dose, but over time, that dose was increased as during the COVID pandemic and people were concerned. The median follow-up is only 14 days and 35% of patients were still hospitalized at the time the data were analyzed. The initial data at 7 days showed a 31% rate of thrombosis, both VTE and arterial. At 14 days, it was 41%, with a rate of PE of 35%. So 25% of those were segmental pulmonary emboli or bigger, 10% was subsegmental, with a lower rate of other VTE and 4% rate of arterial thromboses. Helms had 150 patients. Again, they all received thromboprophylaxis, but you can start to see again the clinical reaction with people changing guidelines. So 70% received prophylactic dose, 30% therapeutic. The median follow-up wasn't stated, and at the time of analysis, 67% of patients were still intubated. Overall, they've got a rate of thrombosis of 42.6%, so very high. A significant proportion of that is caused by renal replacement therapy filter clotting. They have a rate of PE of 16.7% with a lower rate of DVT. So again, both of these studies show a much higher proportion of PE compared to DVT than we see in standard practice. They reported a 2.7% major bleed rate. And interestingly, they did a comparison to historical non-COVID controls with acute respiratory distress syndrome. So when they compared those historical controls, they found overall more thrombosis, with particularly more PEs at 11.7% to 2.1%. So I think this data is really important. I think we have to be aware that the follow-up is short. Thromboprophylaxis regimes change within studies and are different between different countries. Also, because we are all now concerned about the risk of thrombosis, we are likely scanning the patients more than we would have previously. So when it's difficult to compare to historical controls, because actually the clinical care and the threshold for looking for thrombosis will potentially be different. So cohort studies in ICU and non-ICU. So Saskia Middeldorp's group in the Netherlands have reported 75 ICU patients, 123 non-ICU patients. They started ultrasound scan screening of the legs in 25%. The majority received thromboprophylaxis. Again, there's a short median follow-up of 7 days, and 8% of patients were still hospitalized. They reported an all VTE rate of 20% with symptomatic VTE of 13%. Within that, PE was 6.6% and DV 13%. So I thought that was quite interesting actually, because that's a similar proportions to what we would normally expect, that they were ultrasound scanning for DVT, and a chunk of that will have been below knee DVT. They also found that the rate of thrombosis on ICU was 4 times higher than the ward, that if someone once had a VTE, it was associated with a 2 times greater risk of death. Briefly, the next study in Italy, in many ways, changing thromboprophylaxis regimes during the study and short follow-up is similar. I think what's particularly interesting about this study is that it reports that half of VTE were diagnosed within the first 24 hours of admission. And that data is starting to be reported elsewhere. So there is also a question that no matter what we do in hospital once we see a patient, actually a large number of people may have had developed the VTE before they come in. So given some of those very high figures for VTE and higher than we would normally expect at an early follow-up, if we increase the intensity duration or lower the threshold of thromboprophylaxis, would we reduce that risk of VTE? Would we reduce the risk of death? And what is the risk benefit with the likely increased bleeding risk if we increase the amount of anticoagulation? So I've just got a few slides with a bit of data around that so far. So the first headline that really came out was from Wuhan, suggesting that prophylactic low molecular weight heparin was associated with reduced mortality. So this is a retrospective analysis of 450 patients. Only 22% of patients received thromboprophylaxis, and those who did, it was generally standard dose. So from the point of view of the UK, again, this is very different to the care that, the VTE prevention care that we would normally give in the UK, and it's not clear why those patients were chosen to have the thromboprophylaxis. Overall, the 28-day mortality was 30% without a difference in mortality between patients given heparin or not. But in the sickest patients, so those with ddimers more than 6 times the upper limit of normal, or with a sepsis-induced coagulopathy score, which is an early marker of DIC, more than 4, heparin was associated with a reduction in mortality by about 40%. So, but from when we put that in the UK, that's difficult to apply to the UK because we would pretty much be giving all of these patients standard thromboprophylaxis anyway. I think something about intermediate dose thromboprophylaxis, which is being used a lot at the moment, is there's again a lack of data for what it will do. But interestingly, in the Saskia Middeldorp study, they changed between standard dose thromboprophylaxis to intermediate dose thromboprophylaxis halfway through their study for ICU patients. And when they analysed it, although the patients are small, the rate of VTE wasn't reduced. And how about actually just giving everyone full dose anticoagulation? So this has been reported from Mount Sinai, where they've looked at a lot of patients, almost 3,000 patients admitted to hospital with COVID. And they looked at, and 28% of those patients received systemic anticoagulation. And what they found was that systemic anticoagulation was associated with, so this trial shows survival probability, and in blue is those who received anticoagulation. And so the survival appears to be improved for those patients on anticoagulation, and in particular for those who are on anticoagulation who required ventilation. So, I mean, it's a really interesting association, but it is very limited. There's an unknown indication for anticoagulation. It's not clear what other treatments these people were on. The median duration of anticoagulation was only 3 days. And within that, there's an increase in major bleeding from 1.9% to 3%, in particular in intubated patients who had a risk of major bleeding of 7.5%. So we don't have data at the moment to show that increasing the risk of thromboprophylaxis to doses higher than what we normally do will either reduce the risk of VTE or improve mortality. It is likely to increase bleeding risk. So anecdotally, we heard a lot at the beginning that patients with COVID don't bleed. But my concern with that is certainly within the UK, we are not set up to capture bleeding rates. We're really good at capturing thrombosis rates. Retrospective ICU audits of our ICU with a few other centres is showing a bleeding rate of about 12% in patients who are COVID positive, with major bleeding at 7%. And the Right Registry, which is helpfully tweeting rates of bleeding, is similar. They've got 12% overall bleeding in COVID patients with about 5% major bleeding. So it is there. So just to finish up, interim guidelines. If you are torn between being unable to recruit anyone to randomized controlled trials of anticoagulation in the UK, there is a tension in a pandemic to act now. If with that tension you are thinking of changing the guidelines, what might you look for possible risk stratification? So you could go back to the early data that initially came from Wuhan about mortality and d-dimers. There were retrospective observational studies. TAN looked at 183% of patients with overall mortality of 11.5%. On admission, non-survivors had significantly higher d-dimers compared to survivors. And during admission, patients had a worsening underlying coagulopathy, and 71.4% of non-survivors compared to 0.6% of survivors met the criteria for DIC during stay, suggesting that these high d-dimers are associated with increased mortality. And again, ZOO, 191 adults, overall mortality 28%, found that admission d-dimers more than 1,000 were associated with an increased risk of mortality of 18 times. Okay, so you might say that these patients with high d-dimers, either on admission or that worsen during their stay, have the highest rate of mortality. Therefore, if I'm going to increase something, I might choose to increase those patients with the worst prognosis. Or you might say, okay, let's look at the European data that's coming out that we've looked at for thrombosis, which is really what VTE prevention is designed to prevent, as well as mortality. So we know from the studies we've looked at that there are higher rates of thrombosis associated with ICU admission. There's also a higher rate of mortality associated with the ICU admission, particularly ventilation. So maybe those are the patients that we should be targeting. Or should we be looking at traditional VTE risk factors, previous VTE but not on long-term anticoagulation, those patients with active cancer? We know in other scenarios they're at high risk of VTE compared to others. And if we once think about both intermediate dose but also maybe extending thromboprophylaxis, should we be thinking about the community? So within that, there's what I've called hospital-assessed ambulatory patients that are sick enough to come to hospital to be assessed with COVID symptoms but are sent away again for monitoring, and those in the community with milder COVID but potentially at a high risk having had a previous VTE not on thrombosis. So From the point of view of interim COVID thromboprophylaxis guidelines, I think what's clear is that we should be doing a VTE risk assessment on everyone on admission. And if they don't have a contraindication to low molecular weight heparin, then to be giving dose adjusted for weight standard low molecular weight heparin whilst an inpatient. Anything else that we do is not based on good evidence. So the questions that remain that are really interesting for randomized controlled trials are, should we be increasing the dose of low molecular weight heparin? And if we increase it, is it to intermediate dose? Is it to therapeutic dose? Is it just on ICU patients, or is it on others? Should we be giving extended thromboprophylaxis on discharge to patients in hospital? And if so, for how long and with what agent? Because DOACs are not licensed for that indication in the UK, but if you want to give a long course, then arguably low molecular weight heparin isn't very practical. Hospital assessed ambulatory patients, should we be thinking about them because they're unwell enough to have come to hospital if they have additional risk factors? And again, high risk patients in the community. So a lot of that I don't have the answers for. That is expert consensus, and I'm sure we will discuss about more in the discussion. But what I want to leave you with is what I think that our obligations are, which is to keep on encouraging randomized controlled trials in anticoagulation for all of these unanswered questions, because I personally would feel much happier recruiting patients into these trials, which are good questions to be asking, but for which we don't know the answer. If you change guidelines before that trial evidence, then it is essential to audit both thrombosis and bleeding risk, ideally prospectively. And we regularly need to review any interim guidance. Thank you. And on that note, I hand over to Dan, or maybe for discussion.
So if we can just pause at this point, I'm just looking at some of the questions coming through, just to say that you are recommending thromboprophylaxis for all inpatients with COVID, aren't you? They qualify for that under British guidance. So just to make that clear to everybody. And the areas of uncertainty are how much we give, and also whether we give extended thromboprophylaxis. And there is NHS England guidance, which is due out, well, who knows, hopefully soon, recommending extended thromboprophylaxis, although the amount and what you use would be down to you. Susie, that was really, really good. I just want to challenge you on one area, and that's what we're seeing on CT pulmonary angiograms. Now, when our radiologists report, they say pulmonary embolism when they find any obstructive lesion. And that's the same across Europe too. And I would argue, as would many, that when we see segmental and subsegmental lesions, they probably represent immunothrombosis. And if we took those away from some of the reports, for example, the Middledorp paper, there would be very few real pulmonary emboli actually seen. And actually the rate of VTE might be much lower than the events we are seeing on CTPA. Do you want to comment on that?
Yeah, so I didn't go into that in too much detail, only partly because I think that Dan might. So I don't want to preempt too much. But yeah, I think that there is clearly always a huge amount of debate around subsegmental PEs. Of what we've seen, is it definitely there? Is it not? Some radiologists will call it and some won't. So there's always a huge amount of uncertainty around subsegmental PEs.
Or are they PEs, or are they actually thrombosis due to inflammation? Yeah.
And I think there's, and well, yeah, I won't preempt Dan too much.
Okay. Perhaps we should move on to Dan, because time's pushing on. Thank you so much, Susie, and we'll be back to you. So it's a real delight to welcome Dr. Daniel Horner. So he's Professor of the Royal College of Emergency Medicine, Consultant in Emergency and Intensive Care Medicine at Salford Royal National Health Service Trust. And so he's working in intensive care and as an emergency physician at a large trauma centre in northwest of England. He chairs his local thrombosis committee at Salford, and he's led lots of service improvements. He's also done a lot of research around pulmonary embolism, and he's going to talk to us about the diagnosis and treatment of venous thromboembolism in COVID-19. Over to you, Dan.
Okay, thanks, Beverley, for that kind introduction. Thank you to Thrombosis UK for inviting me to talk, and thanks to you all for dialing in to get involved in this conversation and share your experience of the last 3 months, which have been very turbulent for all of us. I wanted to talk a little bit about the things I've learned during the last 6 weeks and the literature that I've read, and how some of that's impacted on our diagnostic approach to VTE, how it's impacted on therapeutics, and also how it's impacting on our general approach to evidence-based medicine. Just to highlight, I do write for an online blog, which is down here at the bottom, stememelindsblog.org, and I have posted a summary of this talk online, which has all of the references embedded and hyperlinked. So like always with my talks, I'd really encourage you to go back to the primary data, have a look at it for yourself and draw your own conclusions rather than just listening to Beverley and Susie and I on this, because it is developing and it is contentious. So like Susie, I'll start from our background. So, you know, in December, what was our approach to diagnosing blood clots before any of this COVID business, and how have things potentially changed? So when we talk about diagnosis of VTE, we're usually talking about a combination of brains and blood tests, I always think. So we use our brains to try and highlight who might be at risk, to think about risk factors and prodrome and physiological presentation of patients to the emergency department or the intensive care unit. And of course, there's lots of work already looking at objective risk scoring. Tools such as the PERC rule, the Wells score, the Geneva score have all been set up to try and give us an objective marker for risk, such that will guide further investigation. And indeed, nice guidance prior to COVID was actually moving us away from invasive investigation by supporting the PERC rule and age-adjusted D-dimer thresholds. There's been work on clinical probability-adjusted D-dimer thresholds and lots of things causing us to really question when we should investigate. But unfortunately with COVID, that's all slightly out of the window. We don't really know whether any of those tools are applicable in this patient cohort who attend with PCR-confirmed coronavirus disease. And in addition, all of our patients that are coming through the emergency department door are hypoxic and tachycardic and unwell. And when there is lots of literature floating around about the risk of concurrent PE in addition to a coronavirus infection, then we all have to think about it carefully, and we all perhaps have to lower our bar for when we want to investigate for VTE. The D-dimer used to get us out of some of these perils. So the power of the D-dimer really is its negative likelihood ratio for patients who we can identify as having a low or sometimes moderate pre-test probability for VTE. A D-dimer below a predefined cut point has a reasonable power to produce a post-test probability that allows us to be confident in ruling out disease. So this is just an example from the BMJ of 2 point-of-care assays and a Fagan's nomogram showing how pre-test probability is impacted by the D-dimer test and gives you a post-test probability result. But of course, this is very difficult to use in COVID as well, because we are seeing from papers already alluded to by Susie, those from Saskia Middledorp, that of 198 patients admitted to hospital with suspected coronavirus or confirmed, over 80% of them will have a raised D-dimer above the normal cut point. So if you know your test is going to be positive to 80 to 90% in people, is it really worth doing at all? Certain groups have tried to reset the bar for D-dimer thresholds. So there's a paper by Leonard Laurent looking at a small cohort of 160 patients, I think, and they found that if they'd set their bar at a D-dimer level of 2,620 nanograms per mil, they would have captured all of their DVTs. But that's a fairly arbitrary number. Is that reproducible in other cohorts? Does their assay mirror yours, and can you extrapolate that evidence? I don't think you can, and I'm not sure raising the bar with D-dimers is the way to go personally. Likewise, when other groups in JTH have tried to apply the idea of a higher cut point, maybe more like 1,500 nanograms per mil, in this paper by Q et al., they find they've only got a sensitivity of 85% using that strategy, which means for 100 PEs, you're going to miss 15. So D-dimer is probably not going to help us in this situation either. Sometimes we're then on to imaging. So chest x-ray, of course, we're going to do in everyone who attends the department with symptoms of coronavirus. And then lots of emergency physicians and intensivists would champion ultrasonography. It's a point of care test. It's non-invasive. There's no harm. Can give you useful information sometimes. And I think that's appropriate in terms of compression sonography for DVT. But unfortunately, our common echo signs of pulmonary embolus are all mimicked by coronavirus, or can be. So severe lung disease causing ARDS and pulmonary hypertension can lead on its own to dilated RV, akinetic RV wall, plethoric inferior vena cava signs. So all of these things that we would usually look at to try and work out if someone had a pneumonia or a PE, unfortunately, coronavirus can mimic both of them. And I'd be interested to hear from all the attendees and the panelists as well about the kind of experience they're having. But certainly locally, I've received multiple calls from colleagues who think they can see echocardiographic findings of RV strain. And when patients are deteriorating in front of them on critical care, it's prompting them to consider thrombolysis and more aggressive interventions. Of those patients that we've discussed, we've pushed forward to image them all, and none of them had significant PE. So it just goes to show how actually those kind of sonographic signs can be slightly confusing in this type of picture. So if sonography is not the answer, then maybe we're into CT imaging. So this is the recommended diagnostic algorithm from the British Society of Thoracic Imaging, and this is freely available online and kind of clarifies the role of CT imaging in those patients who've not got barn door disease, or where you think the degree of hypoxia is not in keeping with the radiological change on chest x-ray, or where you are uncertain and want confirmation about whether pulmonary embolus is involved in the presentation. There's also a nice summary follow-up paper by Sam Hare et al. In Clinical Radiology that talks about the challenges of diagnosing VTE in addition to coronavirus through CTPA, talks about the use of dual energy CT algorithms, and it talks about the bar and where we should set it. And there is advice from the British Thoracic Society on this as well, because we can't CT everyone every day, of course, to try and decide who's got PE. And we can't expose our patients to that kind of risk just because they are progressively more hypoxic from a disease, or because they are not weaning from mechanical ventilation as we think they should. You know, we have to lower the bar for suspicion, but we have to also be reasonable about what we ask of our radiology services and about the risks we expose our patients to from transfer and imaging. And what do we find when we CT these patients? Well, these are the kind of reports that we're getting back, interestingly, which talk a lot about, you know, possibly maybe small subsegmental disease, which is suspicious. And our radiologists will categorize this as VTE positive on their report, as we've asked them to do for a long time, so we can capture incidence. But actually, is this genuine thromboembolic disease, or is this, as Beverley and Susie were alluding to earlier, more of an immunothrombosis, just in situ inflammatory lung disease? We know that there have been challenges with inter-rater reliability for CTPA imaging for a long time, and that's because of the quality of the imaging, and it's because of the diligence of our radiology colleagues, who are great at looking down to very small vessels now. But as Susie was mentioning before, if you put 5 radiologists in different rooms and you show them all the same CT, will you get the same answer? That becomes increasingly difficult as you get down to subsegmental levels. We've also seen this kind of change before with ARDS, not just with coronavirus. And there's a nice review article in Respiration that I was directed to through Twitter last night, interestingly, that covers some of the inflammatory changes and the immunothrombotic changes that we've seen in previous iterations of ARDS. So this is not necessarily a new phenomena when we see this kind of small subsegmental disease in it. And it makes us ask questions about what the right treatment for this should be and what we should do about it. I suppose if we're going to ask ourselves how important that disease is, we need to ask ourselves a couple of questions, don't we? What's the baseline incidence of VTE in critical care? And Susie's already alluded to that a little bit. Is coronavirus causing more incidence of VTE than we've ever seen previously? And what are the histopathological changes that we're seeing with it? So just to touch on those 3 things now. Baseline incidence of VTE in critical care is contentious, and the short answer, I think, is that it depends how hard you look for it. and we are looking very hard at the moment. I would reiterate Susie's point before. If you take catheter-related thrombosis, for example, this JAMA study from 2000 randomized patients to subclavian or femoral vein central catheterization to see what the thrombotic and infectious complications were between those two strategies, and performed surveillance ultrasound screening every 4 days, and they found proximal DVT in 1/5 of patients without any symptoms at all. If you look at PE rates in critical care, most people would talk about symptomatic rates of between 1% and 2%, but actually, if you look at some studies like this one, where for anyone having CT chest imaging, they've added on a CTPA protocol, you will pick up disease in somewhere between 15 to 20% of patients. So it is there, it does exist, this PE in critical care patients, but how hard you look for it depends on your incidence rates, and how much of that is symptomatic and clinically relevant is a matter for discussion. If you look at deep vein thrombosis rates, then again, Susie mentioned their AB PREVENT trial, but this is a follow-up work looking at their DVT incidence with surveillance sonography twice weekly, and they found a 10% proximal DVT rates. Again, most of these patients had no symptoms or signs of DVT, and the clinicians weren't suspecting DVT in this group. So you can see how when papers look at a composite incidence for VTE and you combine all of these issues, you might get very high rates even before COVID if you really start to look hard for VTE. And when we take the papers that have already been mentioned, such as those by Helms et al., Middledorp, Klock, looking at large cohorts, or the largest we've seen of mechanically ventilated intensive care patients, and we pick out the anatomical location of the VTE that's being found, then actually what do we see? Large amounts of segmental and subsegmental PE. Certainly that's the most prevalent disease that we're seeing in critical care when we look at the literature, with relatively low rates of central PE and of proximal DVT. So that's interesting again, isn't it? And that perhaps speaks to a larger problem with immunothrombosis, as Beverley was getting to before, and more in situ inflammatory thrombotic disease rather than thromboembolic. We can follow this up with autopsy studies now, and we've seen a couple of papers published on this recently. This is a slice of lung from Lax et al.'s recent paper in Annals of Internal Medicine, where they performed autopsies on 11 patients, and they found thrombotic disease in small to moderate sized pulmonary arteries in 100% of their patients. There's a section here where they see essentially peripheral arterial thrombosis, and they describe these areas of surrounding infarction that again support the theory of in situ pulmonary thrombosis, adding an additional disease burden for these patients with already VQ mismatch and shunt. So now we kind of understand the disease a little bit more on intensive care. What should we do about it? I think that's hard, and I think the first answer I would say is that no one has the exact answer. I think in critical care, it's really important to remember that all of our treatment options have risks, and all of our patients are individuals. So we need to identify where this disease is in each individual patient. We need to have a think about whether that warrants treatment, and if so, with what. And then we need to think about the risks of treatment, and we need to balance those. And I'll talk a little bit more towards the end about critical care perspectives, but these patients are best served, I think, by sensible MDT discussions and balancing risk and benefit on a daily basis. What treatment options do we have? Well, it seems like heparins are emerging as the winner for treatment of thrombosis associated with coronavirus disease if a decision is made to treat this type of pathology that we're seeing on CTPA. And there are a number of different reasons for that, above and beyond anticoagulation. I draw your attention to Jekko Thatchell's nice article in JTH summarising the benefits of heparin compounds, and we can talk here about anti-inflammatory actions, potential antiviral actions, and endothelial wall integrity. So most of us are using a treatment dose low molecular weight heparins or unfractionated heparin infusions. I think important to point out, and something that I've certainly learned recently, is that due to high levels of factor VIII and von Willebrand factor, maybe our assessment of unfractionated heparin infusions through APTR ratios is not quite as reliable as it usually has been. And I think many centres are using anti-factor Xa monitoring in unfractionated heparin infusions to try and make sure that anticoagulation is done as robustly as possible. Be interested to hear from the panelists about what they're doing and from you all, of course. Should we anticoagulate everyone with heparin if we see such a high incidence rate? Well, Susie's already touched on this, but I think we need to be very careful about that decision. The major bleeding rates in certain trials like this one, I say trials, this is a research letter reporting observational cohort data in JACC from 2,700 patients. Data like this suggests that the major bleeding rate in critical care for patients who are receiving therapeutic anticoagulation might be anything up to 3 times what we would usually expect. So Parangi et al. Report a major bleeding rate of 7.5% in 360 anticoagulated patients receiving mechanical ventilations. That's a real concern. And I think these media headlines that follow on observational cohort data perhaps don't do the paper justice and don't highlight the issues with bias and confounding that we see in the observational cohort work coming through. There are other treatment options, of course, and some people have published case series on tissue plasminogen activator using lower doses, such as 25 milligrams followed by 25 milligram infusions. We've seen TPA before with ARDS, and we've never really been able to prove that it's a beneficial therapy. And these case series are 3, 4, 5 patients, and very rarely do they report anything other than transient improvement in PF ratios or oxygenation, which is of course a proxy outcome and not a patient focused outcome measure. So real concern there about the use of TPA indiscriminately and real concern about its widespread use, especially without a clear diagnosis of central PE. There's also been lots of previous work in ARDS on nebulized anticoagulant therapies, and there are some interesting papers out there looking at these, but I don't think we have any real data to support use outside of controlled trial environments. Interventional radiology has been very tricky for us locally. I mean, there are challenges in getting patients with coronavirus to theatre, and so all of that, coupled to most of this disease being relatively microvascular or small vessel, means I don't think has a huge role to play. And then there is device-related thrombosis, of course. So clotting of circuits, we've talked about, clotting of ECMO filters and catheter-related thrombosis. There are alternative treatment options for these. So regional circuits can be regionally anticoagulated using either heparin or citrate compounds. And we've taken external advice and increased our citrate dosing for renal replacement therapy. For instance, in Manchester, having seen some transient dip in our filter life. I'd make the point here again that filter circuits will clot in critically ill patients and always have done. Reporting that as a composite incidence for VTE is perhaps a bit misleading. I think what most of us will be interested in is filter life and whether your filter life is significantly shorter in coronavirus patients. If it is, there are multiple options to regionally anticoagulate that circuit, in addition to some level of systemic thromboprophylaxis for patients. And of course, devices that have thrombosis related to them can be removed after several days of treatment. So there are options there. And then there are perhaps immunomodulatory options as well. We don't really know that anticoagulation is the right treatment for this type of immunothrombosis we're seeing. And it may be that upstream treatments are the better options. Things like steroid therapy, anti-inflammatory therapy, antiviral therapy might be better at preventing and managing immunothrombosis than our regular anticoagulant options. And most of these alternatives are being explored in trials like REMAP-CAP and Recovery in the UK, where we're looking at different options upstream on admission to try and mitigate the degree of immunothrombosis. And of course, lots more research is coming. So just to touch on this very briefly, therapeutic anticoagulation for coronavirus patients, I think is being looked at in least 3 or 4 trials. There's the ATTACK trial looking at therapeutic anticoagulation for all patients coming to hospital. There's the Rapid COVID COAG, which I think is streaming patients to therapeutic anticoagulation based on D-dimer cut points. There's a REMAP-CAP arm, which is looking at hospitalized intensive care patients. So lots of up and coming research. There's some groups that are looking at tissue plasminogen activator again, and I'll be interested to see what kind of format those trials take and how they proceed with them. And then even dipyridamole is being dusted off the shelf as an antiplatelet agent, and I think is being given credence with the DICER trial to look at whether antiplatelet agents might be effective for this group. But lots of work coming through, and hopefully that will be in the near future. But in the meantime, what do we do? And Susie touched on this towards the end of her talk. What do we believe from the literature that's coming through, and when should we change our practice? That's always a very, very challenging question, I think. For the severely ill COVID patients, I would go back to what I said earlier in the talk about critical care patients perhaps benefiting less from broad-based algorithmic care and more from individual senior MTT-led decision-making. And that has to be informed by a contemporary imaging understanding of coagulopathy, biochemical parameters, and patient history and choice. And we have the facility to have those discussions daily on intensive care due to the seniority of the clinical input and the availability of our wonderful colleagues in haematology and radiology. But we can only make those decisions when we've got accurate, up-to-date information. And imaging of critically ill patients is possible and feasible. Yes, it may carry a risk to wash back the renal replacement therapy, or it may carry a risk to take someone down to CT who's on 80% oxygen. But there's an equal risk to starting someone on therapeutic anticoagulation with no real proof that they have pulmonary embolus or pulmonary embolus of significant size. So those risks need to be balanced. This is a nice and timely paper from our Antipodean colleagues talking about when perhaps we should act on research data that doesn't meet statistical significance or our usual bar for changing practice. And they make 2 points here that really resonate with me in the coronavirus situation. One is that we must consider every new paper within the totality of the evidence. You know, we've got lots of evidence on VTE risk assessment and VTE treatment and the balance of risk with bleeding. So we shouldn't forget that data just because we're in the middle of a pandemic. And secondly, the burden of evidence required to change our practice should correlate with the nature of the intervention. And if we're talking about introducing treatment dose anticoagulation for everyone, or we're talking about using tissue plasminogen activator, then we know that these treatments are harmful. And so we should be asking for quite a high burden of proof that they work before we change our practice. That's all I had to say, really. I will just summarize by just directing everyone again to the notes that accompany my talk and the references contained within, highlighting I think that Joe's going to record this talk. And again, we'll link to St. Emmeline's blog through Thrombosis UK. And that's my Twitter handle, just in case anyone is interested. Thank you for your time. I look forward to discussion.
Fantastic. So thanks very much, Dan. So we've had very comprehensive overviews of thromboprophylaxis and also management of VTE in COVID. Time's ticking by and it's 5 to 12. And what I want to do is to ask you both some specific questions that have been put up beforehand and also some questions that are coming through now. Can I ask you both, what are you doing in your centre about extended thromboprophylaxis in the COVID patients? Dan. Susie, sorry.
Susie, you go first.
Okay. So we had an internal expert consensus group to look at our general VTE prevention guidelines about a month ago. So within that, for extended thromboprophylaxis, at that time, we said that on discharge, to give everyone who could self-inject or practically have someone else inject them at home, to have an additional 7 days of standard dose for wake thromboprophylaxis on discharge. That also included considering for our we see quite a lot of ambulatory patients who are sick enough to be admitted but are then sent home and may or may not come back. So to consider them on an individual basis based on additional VTE risk factors for 7 days low molecular weight heparin as well.
Dan, what about you?
So we are still in discussion about this and have been waiting for guidance, which hasn't quite arrived yet. We have an established policy where we highlight recent updates to NICE guidance and suggest 7 days minimum of thromboprophylaxis for medically ill patients. But we have always introduced a caveat within our guideline that links to the VTE exemplar network publication and the BSH statement, suggesting that that should probably be an individual risk-benefit assessment because our admission times for medically ill patients without COVID are very short, and mandating 7 days of prophylaxis in everyone has always not sat well. So we are encouraging, I suppose, people to look at those paragraphs and think hard about 7 days minimum, but we don't have an established policy for coronavirus patients as yet. We're meeting again on Saturday morning, would you believe it, Beverley? And I could answer that question in more detail after that.
So we're giving 2 weeks thromboprophylaxis. Many of the patients cannot self-inject. They are too old or too weak. So we are using DOACs if we can't get a patient to use low molecular weight heparin. National guidance will be coming through, and unless it's changed, it says to give 2 to 4 weeks thromboprophylaxis, and the International Society of Thrombosis and Haemostasis will be saying much the same. So the trend is to give extended thromboprophylaxis, but we don't know for how long really, but most people are saying for 2 weeks. And I know that someone has just put that question up. We've had some other questions. This is a bit of a challenge, this one here. So we have had a GP ask the vast majority of patients who are presenting in primary care have fluctuating breathlessness, and they are wondering if they should be testing them with ddimers and other tests to see whether they have got sticky blood and whether they should be giving them thromboprophylaxis at home. So the question is, should they be testing them for sticky blood if they're managing them at home, and should they receive thromboprophylaxis?
I saw that question and thought it was a good one. Can I start with that, Susie?
Oh, no.
So we're seeing a lot of patients in the emergency department as well who reattend with ongoing symptoms of breathlessness. They might already have had CT imaging, which just confirmed horrible COVID several weeks ago. So it's a real question then, isn't it? You know, how often do you repeat that? Because of course these patients are at risk of VTE, and we would usually think hard about PE in someone who's had a recent hospital admission and returns with worsening breathlessness. I think, you know, what we're doing in ED is working them up with blood tests, ECGs, chest x-rays, and if their symptoms are out of proportion to what we're finding, then we are pursuing our usual PE exclusion pathways, which would include a D-dimer measurement. I think the worry is that in the community, a lot of the D-dimers might be raised. We might end up doing a lot more imaging. I think until we've done that and had some assurance that this kind of ongoing breathlessness isn't due to thromboembolic disease, then we have to do it to make sure that patients are safe and that we're giving people the best care.
Excellent. Susie, do you want to add anything to that?
No, I mean, I think that was good. It's a very good question. It's a concern. The data that I showed around D-dimers and mortality, of course, those are patients who got admitted into hospital, albeit in a different healthcare system. I think we have to be very careful how far we start extrapolating things like that. Yeah.
So I've also got a question here from Kira Kirk. So she's got patients with moderate and severe COVID in residential care who are not transferred to hospital. And they're struggling with guidance. They normally don't give a thromboprophylaxis in residential care because of the lack of evidence, but should they be giving it to the COVID patient? Susie.
So again, it's a really good question. It's one that we debate out with COVID. COVID appears to be an additional risk factor, but I would be wary about starting to introduce low molecular weight heparin in the community at the moment. I don't know, Beverley, are those in any of the guidelines that are coming out?
No.
Yeah.
So nobody has touched on care homes. And I mean, if we think about the history of hospital-associated VTE, no one has really looked in care homes to look at the rates of VTE there. So we have ongoing issues there.
I think, sorry, I was just going to say, what really concerns me is, I guess the reason we're having the webinar, other people are having a webinar, and these questions are, we are all concerned about this underlying VTE risk. It appears to be a bit higher than we would see in similar diseases, but there are questions around how high that risk is. And what we do know is extended thromboprophylaxis for 4 to 6 weeks, in general, higher risk medical inpatients, the benefit of VTE risk reduction is offset by the increased risk of bleeding. So the more that we do that in the COVID era, and the more that we take that out of patients who have been in medical patients and we bring that into the community, there is a concern that we do more harm than good. And I think it's a really important question, but I would feel much more comfortable doing it as part of a trial.
Could I just add our experience to that, Beverley? So we, within our HAT assessment work, I suppose, and our quantification of VT events, we have seen lots of VTs in patients in care homes locally, and we have quite a fairly sophisticated electronic patient record that allows the same geriatric consultants to look at different care homes and hospitals and monitor progress and report events fairly robustly. So after we saw quite a lot of disease, we introduced risk assessment for care homes, and our aging and complex medicine teams do that now regularly. I think they give less thromboprophylaxis in the care homes than they do in hospital, because I think often they find a reason not to do it, or they think someone's improving so well that they're essentially almost back to baseline and they don't want them to be on thromboprophylaxis for life. But that risk assessment, I think, carries some weight on its own, because it just forces people to think about it and ask the question, should we be considering? And care homes, as you know, will admit and look after a wide variety of patients. You know, some will be bedbound with significant risk, some will be there purely for social reasons and will be at baseline mobility and fairly clinically well. So we've been quite keen on risk assessment for that group, and we feel it's working well.
Okay, one question we haven't actually discussed from Salvatore Cognetti. What about people with coagulopathies who are already anticoagulated? Is there any evidence of dose adjustments or change of anticoagulants to keep a stable INR on, say, warfarin in a COVID patient? What additional challenges does it pose? So, Susie, do you want to take that on, as that's more your area? Do you want to talk about the national guidance here?
Yeah, so I think if, so what's been flagged up to patients on warfarin, particularly for those in the London area where they've seen a huge amount of COVID, is a higher rate of higher INRs. And so if someone is admitted to hospital unwell with COVID, then it would be sensible to switch them from the warfarin temporarily to low molecular weight heparin to have stable anticoagulation while they're in hospital. I wouldn't dose adjust therapeutic anticoagulation and try to do something higher than normal, but if they're not bleeding, if their platelets more than 50, I would put them on anticoagulation, but I wouldn't use warfarin first line in the hospital, because it'll be very difficult to control the INR. Not impossible, but more challenging than normal. Does that? Okay. Oh, did I cut out?
Yes.
Oh.
Don't worry. So just to summarize that, there is national guidance to try to stop people going to the anticoagulant clinic to reduce their risk of getting COVID. So we are switching patients from warfarin to DOACs or even low molecular weight heparin. If someone is on warfarin and comes to hospital with COVID, initially we were switching to low molecular weight heparin, but if they're just on the ward and they go home from the ward, it's often easier to leave them on the warfarin, which is giving a really good protection against VTE, and then switch them over to low molecular weight heparin when they go to critical care. So we've adopted that practice. Can I ask you both what you're doing about anticoagulated patients who come to hospital with COVID? Susie.
Yeah, so we're collecting our data at the moment. So currently we haven't seen particularly high INRs within our patients who are already on warfarin who are admitted, but we're keeping it under a close review. It may be that quite a few of them are already being switched to low molecular weight heparin, or certainly if they are in for a significant amount of time. I suppose, can I just go backwards to the other bit that you mentioned? Because our anticoagulation service in general, COVID has had a massive impact on. So we've still got 4,500 patients across Oxfordshire on warfarin who normally have blood tests at their GP. And it was really challenging for the first few weeks as everyone was worried about seeing patients with COVID and had to do blood tests. So there are national guidelines that have come out about warfarin. And potentially, for those who have a licensed indication, switching them to a DOAC. What I would stress is, within that, prioritizing those people who have a low TTR. a low time of therapeutic range, so those who are poorly controlled on warfarin, and also only switching those who have a recognised indication for being on a warfarin, for being on a DOAC, sorry, and being very careful. So we've had high instances of people being switched who shouldn't be switched from warfarin. And so certainly locally, I would reassure people that we still have a warfarin service, that we are individualizing time between testing. And if you need to be on warfarin, it is still safe to be on warfarin during COVID. And the anticoagulation services locally will ensure that you remain as well controlled as possible.
Okay, time's flitting by, and I'm going to make this the last question, and it's for you, Dan. So we've got two parts of this question. The first is, if someone deteriorates on critical care and you suspect they have a PE and you can't image them because they're too sick or whatever, how are you managing them? And the second question is, how long would you continue anticoagulation for PE in patients with COVID?
Yeah, okay. So for the first question, I would challenge again the suggestion that people on ICU are too sick to scan, because sometimes, yes, the balance of risk will mandate that you can't do anything, but actually that's a conversation to have, and it's not a closed sentence. We've scanned lots of people who have been very sick, but they are transferable on a mechanical ventilator. And that information is absolutely critical to deciding the risk-benefit balance of the different treatment options. And there usually are opportunities to scan people. So it may be that it's impractical because they're on some form of extracorporeal circuit, but most of those will have washback times where you can take them off it. It's usually best done in the day when there's lots of senior people around. And I'm sure you were similar to us that we've had huge support from our anaesthetic colleagues on intensive care because theatres have been relatively quiet. So they've been hugely helpful in facilitating inter and extra hospital transfers. So I think getting the information is key. If someone is so unstable that the consensus decision is that it's absolutely impossible to get any diagnostic imaging, then I personally think basing those kind of decisions on echocardiography findings is misleading, and I don't think it's hugely helpful. I think you can get a totality of best evidence through chest x-ray imaging, blood tests, through echocardiography, but you'll never really know. And so then all I would ever do, I suppose, is escalate someone to therapeutic dose anticoagulation empirically if I felt the potential benefits of that outweighed the risks. But hypoxia is not usually a common finding in pulmonary embolism on critical care. I have to make that point. Usually what we see in patients who have significant PE on critical care is hemodynamic decompensation, or we see refractory acidosis and lactatemia. We don't see oxygen requirement escalating from 50, 60, 70%. If that's happening, it's usually due to de-recruitment, to alveolar inflammation, and to shunt rather than dead space. So therapeutic anticoagulation would be as high as I would go in that setting. And then in terms of how long would we treat people, I think, again, that depends on the imaging, which is why I'm so keen to push for diagnostic imaging. I think if it's a significant size PE, then we would recommend at least 3 months anticoagulation, as we usually would for any VTE that's significant. And then we would consider it to be provoked in the context of illness, so then it would need to be revisited at that point. If it's immunothrombosis, so subsegmental PE on CT, the kind of report that I presented before, I don't think I would go for 3 months. I think I would, perhaps use a shorter period, but again, it would be very much predicated on the risk-benefit balance. And if that patient had particularly high major bleeding risk, I would probably be comfortable not treating subsegmental PE if I felt that there were real risks with therapeutic anticoagulation. And I would just want to watch that patient carefully and hope that that they just improved in line with the disease, just getting better.
Thank you. Well, I think we'll draw it to close now. Thank you both very much for some very good talks. It's been very clear. And I think there are still so many questions left. We might ask you both back in about a month's time to see where we are, because it may well be different. So on behalf of Thrombosis UK, thank you both. Thank you all to those who are listening. Please come back. Please look at the Thrombosis UK website. Just hand you over to Joe, Chief Executive, to say goodbye to. She's organised this. It's a lot of work. Jo, thank you very much.
Thank you very much, Beverley, Susie and Dan, for being willing to do this and working so hard to bring this to life. As you can see, we had well over 800 people registered. I know some trusts have found it difficult to join over the last hour because of firewalls, but just to reiterate that this will, within the next 24 to 48 hours, be available live on the Thrombosis UK website, and I will email everybody when that's available with the link so they can share. And also to reassure everybody who has joined, the CPD certificates will be coming out to you within the next week. A little bit more technology for me to learn, but it will be there. But thank you very much, and please, can we do this again? Thank you. Bye-bye.
Bye, everyone. Bye.
Thank you.
Bye.
Bye.